Next we have Dr. Burton Mckeich from the Kirby Institute.
Good afternoon, everybody. My name is Grace, and today I'll be presenting Australian healthcare provider perspectives on managing hepatitis C treatment during pregnancy, current practices, and pathways forward. So in Australia, we like to begin by acknowledging the traditional owners of the land. I'd like to acknowledge the Bidjigal people, who are the custodians of the unceded land where the Kirby Institute is located. I pay my respect to their elders past and present. I'd also like to acknowledge all the lovely co-authors who have been a part of this study so far, and of course our funders, and especially like to acknowledge the BUMPC community panel, which is made up of a group of women with lived experience of hepatitis C in pregnancy, and their insights have been critical to the development and ongoing oversight of our study. And I have nothing to declare this afternoon. So in Australia, women aged between 15 and 44 years old who inject drugs are 53% less likely than women aged 45 years and above to receive treatment for hepatitis C. Likely reasons for this disparity include reluctance to engage in healthcare due to stigma, also fear of losing custody of their children, and a lack of services that prioritise their specific needs. Treating people in pregnancy may help to overcome some of these inequities in hepatitis C outcomes, eliminate the risk of transmission during childbirth, and prevent transmission to others. At present, in Australia, pregnant people with hepatitis C must wait until they have finished breast or chest feeding before they can initiate treatment. However, as we've just heard from Dr. Catherine, evidence is growing that suggests DAA treatment when given in the third trimester is safe and effective. And indeed, in countries like America, pregnant people can receive treatment on a case-by-case basis. And so as this evidence continues to grow, we expect Australia to follow suit. The aim of our study was to qualitatively investigate current hepatitis C care pathways for pregnant people and healthcare provider perspectives on integrating treatment and pregnancy care. To do this, we conducted semi-structured interviews with healthcare providers who had experience caring for people with hepatitis C or pregnant people at risk of acquiring hepatitis C. We analysed the data using a qualitative method, iterative characterisation, and our coding and presentation of the data is informed by the Health Equity Implementation Framework. This is a diagram of that framework, and it has 4 main domains: context in blue, recipient factors in yellow, peach, and pink, innovation factors in green, and clinical encounter in the square box in the middle. In this presentation, I'll be speaking to 3 of these domains: inner context, innovation factors, and recipient factors, because the most significant data were captured by these domains. So, the results. 30 providers were interviewed in total. As you can see, they were from a range of different disciplines, from addiction medicine to obstetrics and gynecology and infectious diseases. The median number of years in practice was 25. Most providers were from New South Wales. So now I'm going to highlight the different ways providers are managing hepatitis C in the perinatal period. So starting with pregnant clients, most participants that I spoke to said that all pregnant women or pregnant people should undergo hepatitis C antibody screening as part of standard antenatal care. All people who test positive for hepatitis C should then be referred to a specialist, primarily infectious diseases. And just to note here, many of the specialists that we spoke to did say that they received many referrals based on hepatitis C antibody tests alone, especially from antenatal care providers, which just highlights that ongoing lack of knowledge about hepatitis C antibody versus RNA. And lastly, thinking about the infants, you can see there's quite a lot more variability in terms of who is managing infant follow-up and testing, and also when that testing is taking place. So going into a bit more detail about that, I've got the healthcare provider pathways that they described in the yellow, and then this is next to a testing algorithm, follow-up algorithm recommended by the Australasian Society of Infectious Diseases. And for the most part, providers were performing testing within these guidelines, for example, testing at 12 and 18 months for antibodies. For providers who operated outside of these guidelines, they said that they were doing this to prevent loss to follow-up, which is a significant challenge I'll discuss shortly. And so the last point to make about this slide really is that despite having these national level guidelines, there's still inconsistencies in how hepatitis C care is being managed during the perinatal period, and this is even evidenced in local operating procedures. So this one says perform testing at 2 and 6 months of age, and so this inconsistency has been a significant finding for us. Thinking about the successes and challenges of these pathways, to be frank, it was difficult for providers to name a particular success. They did say that for them it was a good thing that hepatitis C treatment was included in antenatal screening, but for the most part, providers described the testing and management of pregnant people with hepatitis C or at risk of hepatitis C as ad hoc and fragmented. When care was seen as going well, it was described as serendipitous rather than deliberate. Pathways were seen as poorly developed and unable to facilitate the long-term engagement needed to be able to offer treatment postpartum and perform infant testing at the appropriate times. Pathways were perceived as especially likely to break down when child protection services became involved in families' affairs. And these challenges are summarised by participant 18, who says, "The cohort that I see, we really struggle with loss to follow-up. Many of the birthing parents are really struggling with their own things, and making an appointment 18 months in advance just doesn't work." In this section, I will discuss what participants thought about who should manage antenatal treatment, should it become available. So for the most part, providers thought it was a good idea. It was seen as a way of overcoming the challenges associated with the current pathways. However, who should be responsible for delivering treatment was something that was contested. Many providers thought that obstetricians should be responsible for hepatitis C care and treatment because obstetricians are likely to have the most frequent contact with pregnant people. However, most participants acknowledged that this was more of an ideal world situation because treatment was seen as very beyond obstetrician scopes of practice, and also they were seen to have very overwhelming workloads. Both participant 15, an infectious disease physician, and participant 12, an obstetrician, said, yes, in an ideal world, obstetricians would be able to offer antenatal treatment. Participant 15 says that even though obstetricians have got so much going on already, DAAs have limited side effects and are relatively easy to prescribe. Therefore, we're not asking obstetricians to do too much. Participant 12 says that obstetricians simply do not have enough time to integrate another service to their workload. Even if the workforce was expanded, Hep C wouldn't be their priority. Overall, providers did seem most in favour of infectious disease physicians managing antenatal treatment alongside obstetricians, especially in the form of shared care models. Shared care models were seen to be the ideal care model because by working together, obstetricians and ID physicians can fill in each other's knowledge gaps. And this did seem mostly aligned with providers' comfortability of implementing treatment. And I'll talk about this in recipient factors. So all infectious disease physicians that were interviewed said that they would be comfortable prescribing treatment in pregnancy. However, there is some nuance here in that they would not necessarily be comfortable recommending it to clients at this stage, especially without obstetric support. Many participants felt that how well antenatal treatment would be integrated into care would depend on how accepting antenatal providers were. Providers who had extensive experience caring for people who use substances seemed to be more comfortable with the idea of prescribing in pregnancy compared to those providers who had less. So participant 12 says, I'm an obstetrician with a particular focus in substance use in pregnancy. I do a few things outside the square, and I might be a little bit more willing to prescribe in pregnancy than some of my colleagues. And the reason perhaps for these differences between providers with experience caring for people who use substances versus those that don't have as much experience is summarised well for us by participant 19. They say, I think what happens is when you are dealing with a cohort where Hep C is such a common comorbidity, it becomes your core business. I can sort of understand the perspectives of those outside, where it would be relatively uncommon, saying, I'm doing everything else and hepatitis C can wait. So to conclude, this is the first study, qualitative study, in Australia to explore antenatal hepatitis C treatment. Interviews highlight the fragmented care pathways that likely prevent clients and their infants from progressing along the care cascade. Interviews also highlight the discordant views regarding who should deliver hepatitis C treatment in pregnancy. Infectious disease physicians and providers with more experience caring for people who use substances did seem most open to prescribing treatment in pregnancy. And of course, while physicians and clinicians have important views that we need to consider when designing care models, at the end of the day, pregnant people are the ones who are going to be most affected, and therefore the next steps for our study will be to analyse the data of interviews conducted with people with lived experience of hepatitis C in pregnancy and compare their ideas of what care should look like with providers. So staying tuned for that at the next INSU, hopefully. And yeah, thank you very much. Happy for any questions.
Anybody have any questions? You can submit them via the app or come up to one of the microphones. Okay, you guys are ready for our next talk, aren't you? Thank you so much. That was a wonderful presentation.